the Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Good morning, George. How are you?
Hello, Dr. Bravo. And how is everything in Virginia? Pretty good, right?
Yes.
Today we have a wonderful guest, Dr. Jean Marconi. Topic of discussion, another clinical report and screening from the AP. Take it away.
Welcome back to the Pediatric Lounge. Today we have a fantastic conversation lined up with a leader in pediatric mental health. Joining us is Dr. Jean Marconi, who many of you may remember from previous episodes where she shared her experience in implementation science, pediatric diabetes, and improving mental health access in clinical practice. We will dive into challenges and opportunities in pediatric psychiatry, sharing insights on integrated care, translating research into practice, and supporting children and families in meaningful ways. Welcome back, Jean. It's a joy to see you.
Thank you so much. Thanks for having me. And I'd like to share and give condolences, Herb, about your mom this week. And I'm sure everyone agrees with me that we're giving you all a virtual hug. So condolences.
Thank you, Jean. The support from the community has been overwhelming, and it's been a great joy for both my dad and I and my sisters. Much appreciated. And many of you have reached out and made donations to the Children's Diabetes Fund that funds the Barbara Davis Center in Denver. And that has made me very happy, and I'm sure it's making my mom smile in heaven. So welcome back. And you've changed roles since we last met. What are you up to now?
Yeah. So I think it's still up the ladder on what the work I've been doing in mental health. So I am now the Senior Vice President of Strategic Partnerships and Business Development at Brightline, which is a national company that provides mental health services to kids and youth, providing psychological testing, therapy, psychiatry, and medication management. Thanks for having me on again.
Is this company virtual in all 50 states, or is it limited to certain locations?
Pre-COVID, it was hybrid. And then when COVID hit, it was virtual in all 50 states and utilizing a lot of EAP models at that time to meet all the needs. And then about 15 months or so ago, recognized that a lot of kids wanted to be seen back in the office. So we're repivot. So now we're hybrid again, focused in the Northeast, New York, Connecticut, Massachusetts, New Jersey. We're also in Washington State and California right now, where we're building out hybrid models in office and then virtual. And parents often will have 1 or 2 visits in the office, and then they really want to flip back to virtual. Or sometimes they trade off back and forth depending upon their schedules.
So tell me again the states you're in.
New York, New Jersey, Connecticut, Massachusetts, Washington, California.
Wow. It's pretty far-reaching.
It's pretty far-reaching, and we have 2 arms. So one is the commercial arm, your traditional referred to a behavioral health provider for diagnostic evaluation and treatment. And then we have a public sector arm that's in California called Bright Life Kids, which is in partnership with the governor and some other state agencies, providing access to all children from 0 to 18. We do the 0 to 12 part for subclinical care. So it's education, intervention, parent management training, things like that, and then some social determinants of health assessment, and then referring on if needed. So whether it's for therapy or other social service systems. So that's our public sector, which we hope to expand on that as well.
Wow. Phenomenal work.
Yeah.
So there's there's a redo of the policy statement on mental health from the American Academy of Pediatrics, and then there's a clinical report on. They really mangle that, and we'll talk about that a little bit later. But I think most of our listeners are not aware of how all these wheels work. And what is the U.S. Task Force on Preventive Services?
So they recommend certain screenings, periodic screenings, their recommendations. It's also how some of the payers decide if they're going to cover those services. And then the Academy adapts from that. It's Bright Futures recommendations, which are what most pediatricians follow, although We can't do all the things, all the bullets that are in there at every visit. It's overwhelming, but those are suggested topics that we can touch on.
So this is a real pet peeve of mine. So there's three different things, right? So there's the task force and there's Bright Futures. And those are codified in law. And that's why when the task force recommends a screening or a preventive strategy, because they do recommend things other than on screenings. For example, they do make recommendations on getting treated after you've had unprotected sex against AIDS, PrEP. They only, because this is the right way to do it, they only consider grade A and B evidence, which means randomized controlled trials that show benefit and little or no harm from the intervention. And the reason they do that is because if you are going to do something to a healthy population, you better be darn sure that it has a benefit and that there's little to no risk of harm. Bright Futures is codified by law under ACA in a similar manner, which creates some problems because the advisors to Bright Futures are, in essence, inferior officers under the Constitution, and they can be fired at will or hired at will by whoever the current sitting president is. That's just the way the Constitution is written. And they submit their recommendations to the HRSA director, which is a department of the HHS, and he or she decides to adopt them or not. And they only look at recommendations for prevention in children. And then the payers, unless it's a program funded through ERISA, have to pay for that intervention. And the important thing there is with no cost sharing to the beneficiary. I don't know what level evidence they use. And then there is getting on the periodicity schedule, which does not have to have government acquiescence or approval. And for the most part, the American Academy of Pediatrics uses the minimal standard, which should never be used for recommendations for population-wide population health, which is expert consensus opinion. These are not randomized trials. They're not prospective trials. They're just the opinion of the people that got invited to the meeting. And that is the lowest level of evidence. And I think most experts on population health really feel uncomfortable using that on healthy populations because there's more risk of harm and because we don't know what happens. So for example, and this always causes a lot of friction between the task force and the AP. So for example, in obesity, the AP recommends use of GLP-1s in children over 21 for treatment of obesity. And the task force says there's no long-term data on outcomes or safety. The study was barely a year long, and that's not enough to recommend an intervention in otherwise healthy populations. So those are really big key differences as we go through this. Then the academy makes it a little more complicated. They have a policy statement. Well, what is that supposed to do, Jean?
So the policy statement is for us pediatricians or those that take care of kids, recommending things we can do that either improve health or cause an intervention so that bad things don't happen, such as mental health screening is one of those. They put the recommendation out. It does not always come with a fiscal note or that the insurance is definitely going to pay for it. It's a recommendation. So for example, the screenings, certain payers only pay for 2 at a time. They're now recommending 3 or 4 maybe at a certain age. Again, how do all of these connect and how are we sure that, that they're going to be covered, which is clearly you want to provide the best practice and quality medicine, but we also need to make sure that 1, we have time to do it in the allotted time that we have, and 2, that we have resources to take care of things when we screen, right? And then the third one is that we get paid properly for the time and energy and efforts, all of the tooling that we need to actually do some of these things.
So the policy statements are in some ways not they're aspirational, not evidence-based. So, for example, Jesse Hackle just wrote a policy statement urging each state to adopt laws that there are no religious exemptions for vaccines to enter school. And that's just aspirational public policy and part of the advocacy, right, that they do. We know that in the US in 2019, which is the last time that they published data, the number one reason for hospital admissions in the age group of 10 to 14 was depression. The number 3 was diabetes. And they far exceeded asthma, for example, or cancer. And so these policy statements from the EP are meant to urge change, not only from the pediatricians, but the policymakers and the politicians to benefit children. And then there's a clinical report, and there's a new clinical report on screening, right? And the clinical reports, they are more expert opinion consensus than they are graded evidence-based. So they update the pediatric community in the sense of the pediatric clinicians on what the up-to-date information is on a topic. And then finally, they have the highest and the most cumbersome one, which is practice guidelines, where they actually grade each recommendation, A, B, or C, A being randomized controlled trials, hopefully double-blinded, and then very solid with a good number to make sure that there's statistical power in them. And so this statement that they put out was a clinical report. So it's in the middle. And I found it very difficult. I got lost in all the jargon. And I don't understand why they put together emotional wellness, mental illness, and developmental disorders into one lump. Was that to make it seem like it's a greater
No, I think, the approach there was, it's a holistic screening, right? There are differences between behavioral screening, developmental screening, and mental health screening. So they're calling it MEB now. So mental, emotional, behavioral.
Okay.
They're a little bit different. And different screening tools fall in the different categories. And if you think back, I think in 2000 or the late 90s, we started doing the developmental screenings, right? There were screenings before, like the Denver and all of those that, we used to use like very early on, and which weren't so specific either. And they were also time consuming, right? So that led into, in the early 2000s, like coming up with some of the MCHAT or some of the ages and stages, right? So that we used at 6, 9 months, 12 months, 15 months, 18 months. And then around 2010, 2005, 2010, started thinking about mental health screening. So then there was like the depression screening, right? That was the only one at that point. And then in the mid-teen 2000s, we started using the pediatric symptom checklist, which was like the parents' screening of their child until a certain age. And then the child or young adult could answer those questions themselves. And then over the past...
So tell me more about that one, because I don't use that one, and that one really confuses me.
So the pediatric symptom checklist is a validated screening tool that has 17 questions or so on it. And you can use it, the parent can fill it out till the child is 11 or 12, until the child can fill it out themselves. And it's very broad questions, like, does your child have a lot of tantrums? Does your child sleep well? Like, it's an overall screening of, like, when a pediatrician can look at it and say, okay, these are the areas that are concerned. It might not tell you exactly what it is, but these are the areas that are challenging. And it helps us as a pediatrician, because when we go into the room, we say, okay, we're going to hone in on sleep. Look, there's all these like concerns about sleep. And then the child can fill it out. Do you have concerns about your sleep? Do you have concerns about your well-being? Are you a good eater? So it's like an overview. So that's why they call it like a symptom checklist. So it's not really putting you in a diagnosis, but it's collecting information on where there might be issues that you can direct your focus during that visit. And then I would say in the last 5 years or so, a lot of work, especially with the escalating mental health, is, okay, how can we identify some of these kids earlier before we have these escalations and we have these numbers that are reaching critical masses. What else can we do here? So that's where suicide screening became available, and then depression screening, and now anxiety screening. And if you look at some of the numbers, like 17% of 2 to 8-year-olds have a behavioral health disorder, and most of it is anxiety. And is that from
Okay,
the
so
pandemic?
so here's where I am.
Like, how
I'm
do we
really
deal
a
with it?
stickler for this. Okay, I
Yeah.
do not like what the AP is doing. Don't bundle things like the insurance company. Tell me, like, what percentage have developmental disorders? What percentage have mental illness? What percentage are stressed because of their social environment? But don't bundle it together, because I am very cynical and I think you're bundling together to make the problem look worse than it is. And then when it comes to anxiety, look, there is good anxiety, which the three of us suffer from, or George calls FOMO. And then, of course, there's pathological anxiety. But good anxiety is the idea that I knew I had committed to this podcast and I needed to get the questions done. And it made me feel uneasy and I got it done. Or you don't want to fail your schoolwork and you get your homework done. And that should cause a little bit of distress. That's what motivates your reptilian brain to do. So how many of these kids that they're labeling as anxious are just people that for survival reasons, we should have some fear. I should not go into a bar and try to pick a fight with 3 22-year-olds with guns in their belts. It's just stupid. I should be afraid of them and I should walk away. So how many of these kids have what I've considered physiological anxiety for survival, and how many of them really have a disease?
So I think that you can say that with the crisis that we have to look backwards, right? We have all these escalations. We see it. Kids are chronically absent from school. The emergency rooms are overwhelmed with kids that are being referred in because they're so sad, or they beat up somebody at school, or they tried to commit suicide in the bathroom. Those are real cases and real numbers, right? So when you go back and look at how the CDC collects the information, now I can't speak to how they collect the information, but they collect the information. And if you have a child that falls outside of, because what's the value of a screening tool? The value of a screening tool is that you're looking for something that's been validated, that when you repeat it or when you do further testing, that it's either positive or negative, right? The positive doesn't mean they have some disorder. It means that they failed the screening and they need further evaluation, right? So let's just be clear about the screening tool. And then the value of that screening tool only has value if you can do something about what you find. Because there's no point to screen for something if you can't do anything about it. So I think, and that's where we get into trouble, right? Because people feel like, why should I screen? Because I don't have any resources in my neighborhood, or I don't have one more minute in my day to see one more child who's telling me that they feel sad all the time and they've thought about hurting themselves. So they're not suicidal at the moment. Maybe they've had some ideation. So I think if you look at the data from that way, and the CDC data is what I use to look at, and it is increasing from, we've been following these screening tools for 25 years now, more or less, not all of them, but a good portion of them. And we did see with COVID, which was an extraordinary event, the incidence of all of these disorders went up significantly, and they went up even more significantly in the younger age group. So we're seeing a lot more behavioral issues in 2 to 11-year-olds. And I can confirm that because we've done schoolwork. We have contracts with schools, and it is not unusual to have a 6-year-old come in and actually say, I'm depressed. Why would a 6-year-old even know that word? Do you not? So again, there's just so much of this around, and think of all the traumas that kids are going through that they can see. Years ago, we didn't watch TV or have access to all the social media and see every school blow up. Like now, kids know whenever there's a shooting at any school. And what that does is it triggers the memory again. And it's another event of an acute traumatizing event, right? We know ACEs is going up for a variety of things: poverty, housing insecurity, food insecurity, all of these like terrible, violent things that kids are now having exposed to because the TV's on or they're on their phone. So I think we have to trust some of the data, Herb, and I understand what you're saying. Like some of this is just normal behavior, and are we over identifying or labeling kids? But I am looking at this, I'd rather over label than under label. And we know that by age 14, 50% of kids who have some mental health disorder are going to have it for the rest of their life. So we have to find a way
Oh, I'm not
to
disagreeing with
intervene early or provide education. So the best
what.
we have are some of these screening tools. Like, how else are we going to know?
No, so you're right. So what I'm saying is, and I like what you just said because I forget this often, is that the screening tools are not they do not a diagnostic make. They are like a warning light. And then you have to use your clinical acumen to make a decision whether this is the diagnosis or not. I think COVID was terrible. And I think the way that they closed the schools created a lot of trauma in children. And the academy has never apologized for that. They should stand up and say, that's what they teach you in communication school. And when you're wrong, the quicker you offer an apology, the less harm you do. And the more that you deny, the more harm that you do. I think it's understandable. I felt anxiety. I did not want to get COVID without the vaccine. I always say end up in the PICU, but I'm too old for the PICU. But I didn't want to end up in an ICU and end up with a tracheostomy and then have to go half dead into a nursing facility for 6 months for rehab. I really feared, and I feared from my parents who were in their 80s when COVID hit. And, that is anxiety.
I think we all had it, right?
But,
Even us
but I don't
in
think that's
practice, we had to close
pathological
our doors.
anxiety.
Yeah.
That was survival anxiety. If you can't get past of it, we're not vaccinated. At least I'm vaccinated. And so I fear it a lot less. I think COVID is a cold now because I've had it 3 times and I didn't end up in the ICU. It's also like right now, we buried my mom, and I think it would be pathological if my dad, my sisters, and I wouldn't get tearful. There's a grieving process. And we used to call it a reactive dysthymia or depression. I think the pathology starts when, after a period of adjustment, you can't move past it. And we're certainly, I think, seeing that with the kids.
Yeah. And it
They're
also
not being
depends
passed.
on what coping mechanisms you had or how you've been trained to deal with situations. Like some of it
And
is,
how resilient you are, which
yeah.
it's a very interesting part, but not well understood. Some people can tolerate tremendous amount of trauma and still be happy, and others wilt away with a little rain. So yeah, no, it is increasing. It's a real problem. Screening tools are important, but I think that's a very important thing that you said. They don't make a diagnosis. They are a warning light, and you got to use your clinical acumen to make the right diagnosis.
Well, the problem with all these screening tools, it's a good idea to screen. You look for things. If you look, you will find. If you do universal screening, you're going to find a whole lot, which is great. Well, what do you do with them? That's the problem.
One of the options is what our company is doing. She's improving access to mental health. So that's one of the things. In Jean's former's life, and you've done a little bit of this, they've embedded mental health within your practices, which helps. And sometimes I think the intervention is not that, it's funny, the intervention is very simple. A kid with not a major anxiety disorder, a mild anxiety disorder, you can teach them the ABCs. What was the adversity? Because we all have adversities. What was your belief? What did you think was going to happen when it was raining outside? Could something else happen? And then how you define the C as a consequence. That takes 5 minutes to teach someone. And if they're just mild anxiety, that is very helpful. You were going to say something, Jean.
Yeah, I think it's compounded, right? There's all of these gaps, right? There's gaps in our training as physicians, right?
Yeah.
We have very little psychiatry or mental health when I trained, and I bet you they have less now because they're less time in programs, right? Because they have this time off.
Yeah.
And they're coming out more experienced in chronic care or acuity care, right? Where are these experiences of new doctors coming out that have continuity of care in a clinic setting that can follow some of these things? So I think there's a hesitancy on the part of providers to actually want to screen because not that they don't want to, but they don't know what to do. They're not comfortable with what you just said. I would bet half of the pediatricians don't even know some of those, like the 3-3-3 rule. Okay, here are 3 things. Think of 3 things. Think of 3 moving body parts to calm a child down who's in the middle of panic in your office. Not a lot of us know some of these tools because they've never been taught. Not that they wouldn't want to, they just haven't been taught or had the opportunity to practice. Then you have gaps in parent identification of these things. Like parents are less near their nuclear family. Parents are really busy. A lot of the parents are traumatized themselves from COVID and haven't recovered. So you have a traumatized or a limited parent with a child who may be experiencing some of these things, but not recognizable because they're not really sure what to look for. Like tantrums at 3 or 4 that are out of control. Oh, he's just a bad kid versus there's something else going on here. Then you have gaps in the system. Like we don't have coverage for good mental health. The marginalized populations, no one wants to be on the Medicaid plan because they hardly pay anything for a visit. You can't afford to hire a social worker for what Medicaid might pay. And then you have high deductibles. So all of behavioral health goes to deductible. So parents are hesitant to come. And if you look at the data, 75% of kids who go for behavioral health hardly make it to the 2nd and 3rd visit. So then we have the kids identified. There's lack of compliance. There's lack of nurturing through the journey. Parents need their hands held by a care manager or somebody to go through that. So then they're back in the system again. And then it's worse. And then it's worse. And then it's worse. And then we're at the point where it's an emergency room visit. It's a partial hospitalization program, intensive outpatient, you name it. And now it's really costing a lot. So there's gaps in the system itself. And then in the place where we could address it the most, where kids spend most of the time, where do they spend most of their time? In school. School has become the default place now because pediatricians can't see the kid. There's lack of it in the community. Where are they going to go? So the teachers now have been burdened with trying to deal with a lot of these kids with limited resources. So now the teachers are getting burnt out. And the schools don't want to do any screening preventatively because they don't know what they're going to do with a positive result. And they feel like they're liable for something. So it's a mess. It's a total mess. And I think it takes multiple villages and multiple mountains that are going to address this problem. But I think what pediatricians can at least do is help identify them early and figure out how to provide intervention and make a resource manual or list in their practice. Find pathways that can help your patients. It's all about connections. It's all about who you know. Like George, your group takes care of some behavioral health. If you do the first level of care, you'll find other more trained people in your community that are willing to take your patients because they know you've already tried. You've already tried whatever modalities that you have. Now, if you're in rural places, that's going to be tough, right? Because there aren't people around. So what telehealth services can address your community? Like where can you find companies or service lines that are able to attach to your patients maybe in a different way? Or does it make sense for you to hire a social worker 1 day a week to treat some of these lower acuity? Go take the Breach Institute. It's a 3-day course for pediatricians where they could do like lower level. And honestly, I think there have been times where practices are saying now they don't have any visits. We've cured a lot of the vaccination issues, but now we're dealing with obesity and mental health. So like it's time to reinvigorate your education, find ways to become more educated. And this hurt with the diabetes, like there's so much to learn now, like cutting edge, how to intervene early. So like when that BMI gets to 95, like you need to do something. You're going to have a type 2 diabetic at 14 years old. So this is not different than some of those things. The same thing with asthma, right? We have so many controllers now, and we're able in private practice to take care of so many more of those higher level acuity asthmatic. We need to treat mental health the same way. It is a
I
part of,
agree, but
right?
that's a different problem, right? So what you're talking about right now is another thing that really drives me nuts. It's the American Board of Pediatrics, right? In the ideal world, we would do away with recertification. And what we would have is exactly what you just described. Practices would evolve and they would be compensated for doing this change. Like you would learn how to better treat asthma with smart therapy. And then you would join a Project Echo. Like George has got a big group. He's got 16 doctors and 2 offices and all that. So there's somebody in there that really likes pulmonology. And they could become the subject matter expert in transitioning all their asthmatic kids to inhalers and smart therapy. And that's what should be rewarded. Not just, let me see this esoteric disease that nobody sees, but we're going to pimp
Right.
you with. Somebody else might take the bandwidth of mental health and become a clinical expert in mental health within his group. Someone else would become a diabetes expert within that group. And that way, I think it's more fulfilling as human beings because pediatricians are very smart, curious people. And then you are teaching them or her new skills. And that I think prevents burnout because it's super interesting to learn a disease process and how it's evolved and what you can do differently. But that's such a big paradigm shift of how we're doing things today.
Yeah.
But it needs to happen. We know adults don't learn sitting an 8-hour session. 8-hour CME is for school kids, not for adults. The room's cold, there's no sunshine, you lose interest about after the first 3 lectures because you start getting mentally exhausted. And these are not rote math like 2 plus 2 is 4, 4 plus 4 is 8. No, these are high order thinking that take a lot of energy. And without the repetition and the peer support, you don't learn it. And that's where we really need to do. But anyway, I was going to ask you about the SQS, and I'm going to ask you more later because I think we still haven't been able to reach the audience in a way that they understand it. But this is one example where the clinical report from the EP is urging every pediatrician to do ASQS screens. I think on kids over 12, right?
So, yeah. So, suicide screening for kids over 12 or younger when appropriate, right? So, if
Okay.
there's any risk factors. They're also suggesting anxiety from age.
Well, I'm going to break it down one by one.
Yeah.
The problem here is that the U.S. Task Force on Preventive Services has said it should not be used population-wide because there is no grade A or B randomized controlled trials that show in healthy populations screening for suicide, we have a positive outcome. There's just the data is not there. And there is a risk of harm when you do these interventions. And so
What's the risk of harm on doing a suicide screen?
Asking the question only. You might
you're
find an
asking
answer.
a question. Maybe the patient.
There is no harm. There's only a benefit. And I will repeat.
What's the benefit? You can't show me an article that shows that it decreases the rate of hospitalization or the number of suicides in a population. The studies don't exist. That's why the task force says you cannot do it population wide.
I think that there's a lag there because we know the suicide rate is increasing. It's increasing in kids ages like 5 to 11 now. Like the age of suicide is going down. And what's very clear, and there are studies on this, and I'm happy to send them to you, that half of children or half of people who commit suicide see a clinical provider within the week before they actually do it. And more than that in the 30 days before, which is often not your primary care doctor. So we have a huge opportunity, and I can tell you a study I did myself, and I replicated another study. 5,000 kids got the suicide screen. We had a 4% hit rate, and half of those were serious, like that needed to go to the hospital on a visit for not a mental health complaint. And the problem in kids is, I can tell you this, because I've done the work, there are not a lot of retrospective or prospective mental health studies in kids, period. So we have had to be using adult data for the last several years. So I think that, yes, we need more data, but also we have a crisis on our hands and we have to figure out how we're going to deal with it. More than half of high school students in the CDC youth, their own reported study, have said they feel depressed. 10% have tried to commit suicide, and 10% have tried more than once. So we can't ignore that data. I understand that you want higher level data, but we are living in the reality now of this crisis, and we have to have some way to figure out how to address it. So the best way to do that is to screen everyone, because we don't know. Mental health is quiet. It's not like it has symptoms. And most parents who have a kid who committed suicide, 90% had no idea their kid was suffering that much. So clearly it's like the silent disease. So I don't know how you do a study on something that's so silent versus if they have diabetes, okay, they're having symptoms that you can actually see and measure. Mental health is not that. So we need other ways. I agree with you. Maybe it's not the best, but it's the best that we have right now. And we are making a difference using those screening tools. And we will change the trajectory of that kid's life. If we can help them in youth before they're age 14 and intervene and give them the skills, we're going to produce healthier adults. And therefore then healthier kids, because they're going to have healthier parents. So that's my soapbox.
No,
Hold
I'm
on.
conflicted. I'm conflicted.
Her practically, what Jean says is correct. I am in the field. I have personally, in the past year and a half, had 3 cases that came in for a checkup and the parents were clueless. They filled out that PHQ-9 and there was a suicide question, few questions in there, and they were positive, very positive.
Okay, so I'm going to push back. The parents are not clueless. That's not fair to blame them or feel bad. The children often will not share their feelings, and the adults around them are totally unaware of what they're feeling. And that's something that I want the audience to hold on to, because we're going to talk about this in a little bit.
Because you can't do the online fill out the form kind of thing because the parents fill it out. So you have to give them actually a piece of paper and have the kid fill it out without the mother watching. Now, what happens when the kid is suicidal in there for a checkup, Jean? There goes A.
There goes your day. There goes your day. So if you don't have...
I'm the kind of a person that has to resolve problems, okay? I don't want to say everybody goes to the emergency room, do this, do that, and turf it to somebody else. You have to... My process was, okay, I look at the PHQ-9 pretty much before I even do the visit or very early on. So I see if there's a problem. I see there's a problem. I did the preventative care visit. I did the checkup. I did everything you're supposed to do except for the PHQ-9 results. Even ordered the vaccines. Got the vaccines going. And very end of the visit, I asked the kid, hey, what's with this? What's with this question? Is this real? Is it not real? And the kids usually are shy and whatever. And then I asked the mother, can you step out? I want to talk to your child a little bit. Talk to them a little bit. Figure out what the story is, how severe they are. These 3 kids ended up going to the emergency room and admitted into the hospital for 2 weeks. Okay? The mothers knew that the kids were a little upset, but they're pretty much, they didn't realize the severity of the illness. Now, that took a lot of time. Fortunately, with technology today, with the medical scribing, the note is there. It's written. It's better than I could ever write. Back in the old days, you had to write that progress note. They'll take you 3 days, right? Now, you just did your thing. I didn't stay and I didn't get embroiled. I didn't stay for an hour. I wanted to see how severe the kid was, and he was severe. Then you bring the mother in. You tell her, look, I got this out of the kid. With the kid there, the kid validates what the concerns are. And you have to send them to the ER. My process was, you have to go to the emergency room at this designated place. I'm going to call them and alert them that you're coming. The mother says yes, and I'm going to call you within an hour or 2 to make sure that you're there, make sure everything's okay. And then the third statement is, because Herb will say, what if they don't go? If you don't go, I will call the police to come visit you. Now, is that right? Is that wrong? This is the Rogu method. That's what I did because I was under fire. I had to resolve.
Yeah.
You know how to
Like being
build
a mandated reporter. You're being a mandated reporter, basically. Like the kid is in harm's way.
I
Yeah.
did, and we did actually the sad story with one case, a teenage, like a 12-year-old, 13, 14-year-old. She filled out the screening questionnaire. It was not very positive, but a lot positive. So by the time they got them into their network to send them to where they got to send them, the poor kid actually committed suicide.
So
That's a problem.
yeah, let's address the first point. Pediatricians are woefully underpaid.
Yeah.
2, we have been asked to take on the work that public health should be doing in many instances, and no one allots time for us to do that. No one pays us to do that. That should be the government's job, and we're not doing it. What you just described is no different than I walk into a room, which happens, and the kid is retracting, wheezing, and the pulse oximeter is 93%. And excuse the language, I'm going to be beep Prasad on you. It is a shit show because the parents have had this infant at home for 2 days wheezing, and you say, what's going on here? And they're like, nothing, he's got a cough. He's breathing like you put them on a treadmill, and he's winded.
Yeah.
Didn't you think you should come earlier? He's all right. He just needs some cough medicine.
And but in residency, you saw 20 of those in a day, and you were used to dealing with a lot of them at the same time. You're not
you
used
got to take care of them. And then you had a bad experience with a child with type 1 diabetes, where they came in, you flagged them to return for the workup because their hemoglobin A1C was elevated. She never returned. She came back 9 months to see the urgent care side of your practice, and she was outright hyperglycemic with symptoms, and right into the ER and into insulin she went. And what can you do? You asked her to come back. You were going to screen her with the autoantibodies. You could have probably given her the only medication that can delay the onset of insulin, but they didn't come back. And so that's going to happen. So unfortunately, the patient that died by suicide in your practice, they didn't come back. They didn't follow the plan. And we can only, if we try to live medicine by 100%, we really will put a bullet in our heads, because if we can do,
but what about the other 2? He saved 2.
The other 2 he saved. So we have to focus on those.
So 2 out of 3 is good.
Yeah.
More than good. That's awesome. He'd be making $2 million a year if he was a baseball player. They only hit 1 out of 3.
Yeah, but so I want to talk about, there is a way to get paid for this work, and maybe it's not appropriately, but I think a lot of pediatricians, providers don't stay up on their coding, and they don't know how to make this work. If George got interrupted and he had to spend another half hour, whether it was for asthma, mental health, kid might come in dehydrated, you got to throw in an IV, a baby may come in with a high fever, or you need to orally rehydrate, right? Mental health is not different from that. And I think that's where we fall into problems. There's this stigma, and I don't mean like a emotional stigma or physical stigma. There's a stigma among people wanting to take care of it. I don't want to take care of, when I was like in medical school, I don't want to take care of old people. It's like that, right? I don't want somebody over 60. They're smelly or whatever they are. Like, right? So you have this preference. And I think in the medical field, there still is that kind of stigma of taking care of mental health, because they don't know how to do it. And it is a little bit more complicated with the care management. But now we know that you can get paid for extra time. It's all your time. So it's reviewing that screening tool, talking to the parent, calling the emergency room, talking to the patient, charting. As long as you do it on that day, you can get paid for all of that time. So it does make it worthwhile. You can also get paid. Okay, now you've seen a kid and they're just depressed. They're not suicidal, but they need care, right? Okay, so you write a referral you order a referral, you have your referral secretary, whoever you have doing them in your office. Okay, I got to see what they have. I have to call around, see where I can get them an appointment. I have to call the mom back. You can bill for that. A care coordination code. Most pediatricians have no idea what that code is. Now, it's 20 minutes of work, that clearly takes 20 minutes. And it's $40 or $50. Why aren't people using this code?
Well,
Right? So some of it is their own fault. They need
absolutely.
to
But Medicaid,
update
Medicaid in
on
Virginia
coding.
Medicaid does not pay for care
Yes,
coordinating.
they pay for that code.
Not Medicaid, not Medicaid in Virginia. It's the
Okay,
stupidest
well,
thing.
Medicaid in New York pays for it. They
And
pay for that code. But that's where advocacy has to come in and talk to your state chapter. Like, there's ways to go around some of this stuff that I feel like sometimes we're our own worst enemy. There are ways
oh
to
yes,
how you provide
there's
this.
people that go, oh, her, please don't. If you see a child for a well child, like what George is describing, that's a well child visit, and 99215.25, because dealing with suicidality is not part of your well child disease, and this is an emergency, and it's making me transfer this patient to the emergency room, and it's an uncertain outcome, and but there's a lot of people that if you were just to bill and add on 99213 to that, they're like, the insurance company complains about me having too many ENMs with well child visits. That's because your patient population is really sick. 85% is Medicaid, underserved with ACEs and social determinants of health. And you shouldn't apologize. You should just do it documented. And then when they say something, you pull out a report from your EHR and say, 85% of my patients are Medicaid. 85% of them are not white. And this is the incidence of depression that I have in my practice. And these are high risk kids. It's not my fault. You're supposed to pay for the work. And you send a copy of that to your local representative at your state level and say, and they go away. As long as you're not cheating, you're not making up diagnoses.
No, you have to make
If
sure
you're doing the work, you should not be ashamed to get paid for doing the work. And you should not let the health plans bully you into not charging for the sick visit just because they just want you to bundle it with a well child exam. But the parents do the same thing. If they have a high deductible, they're livid that you charge them for managing the disease. And it's
we're the middleman. We're the bad guy.
yeah, you could come
the
back
bad-
tomorrow and we could address it if you want to. You're already here.
Yeah.
So anyhow, we're getting off topic. I want to ask you, because I got totally confused with this paper and I can only get to certain part of it. So when are we supposed to be doing developmental screening? I always do it 2, 4, 6, 9, all the way through 3 years of age, but the paper has different numbers. So when do we do developmental screening? Whether it's
So,
the Denver or what is the ACE-Q?
ages and stages.
Yeah, or the
So-
one from Tufts. Tufts has a lot of,
So this was one of the problems with the paper, okay, is they just said screening, but they don't tell you which ones. You are a man on an island and you have to decide for your practice what is going to be your screening regimen and when you're going to do the screenings.
yes.
Everyone does it differently. There isn't
Oh, yes.
or a wrong way. So you have to pick what's right for your practice. So everyone should be doing the Edinburgh, right? Maternal depression screening through this 6-month visit. And then you can be doing ages and stages at 6, 9, 12. And we're doing an MCHAT at 12 months. We're doing an MCHAT at 18 months. And then some people will bring
No,
kids.
so I'm going to break it up. Okay. Please keep it simple because this is my weakest point in medicine. Developmental screening is not MCHATs. That's not a developmental screen. Edinburgh is not a developmental screen. When do I screen for development in children according to the academy? It is not as I'm doing. It's not, I do 2, 4, 6, 9, 12.
8, at every
15.
periodicity schedule. You should be doing a developmental screen.
I do a standardized, validated developmental screen. Okay. So that stays the same.
That stays the same.
Okay. All right. Because it seemed like they had different dates on it.
That was
Then autism is not a developmental screening. It really is. And you charge it, you should be coding it differently. It's like it gets coded with the same as the Vanderbilts or Connors.
a 9-6, just for everybody's benefit, a 96127.
Okay, and that's a very important thing for people to know. You don't charge the MCHAT with the same CPT code as you do
the developmental, which is the 96110.
And sometimes you're going to do the developmental and the MCHAT at the same visit.
Correct.
Okay, because you're screening for normal development and you're screening for pathological disorder or neurodivergence. And the MCHAT, if you choose to do that because of Tufts also has one that they validated. But whatever validated tool you're going to use for autism, you're going to do that at 18 months and 24 now, as opposed to, we used to do it at 18 months and 30 months. But now we want to do it sooner at 24 months. Is
Yeah.
that correct?
That's
Okay.
Yeah.
I can handle that. Anxiety, I use the long version of the anxiety. I don't use the
You use the scared or the snap or
scared. I use the scared, the long version of it. I don't use, there's a GAD, is it
there's a
GAD?
GAD-7 and a
Yeah.
GAD-2, actually.
I use the GAD-7. I don't use the GAD-7. I use the whole big one. And I only do it when I feel the child's anxious, or as a part of a workup for, say, autism if the child's old enough, or if I'm working a kid with hyperactivity or
That
attention.
makes sense because you shouldn't be using the GAD-7 until the kid's a little older, like between
Okay.
12. Below that, you can use the scared or use the snap or some of the other ones.
Scared, what? Because the scares takes a lot of time.
It takes a lot of time. It
The
does.
scare takes a lot, and they're recommending that you start that routinely at 8 years of age every child. That takes a lot of time. Takes a lot of time for the parents to fill in. Takes a lot of time to score, and takes a lot of time to interpret. That's not in Bright Futures, is it?
It will be. They're moving all of these will be recommended. Like, I think that they don't review Bright Futures. Like, they don't update it as it comes along. I think it's a 3-year cycle for Bright Futures, if I remember correctly.
But-
Don't hold me to that,
No,
but I know
But
there's
Bright Futures, it has to go through the process. It has to go.
yeah, it takes a while.
It has to go. HRSA has to open it to public comment.
Right.
And then if there was an HRSA director, because Dr. Warren left, he got dodged. And until then, the payers are not forced to reimburse you for it. They can just bundle it with the well child exam.
Well, I think the idea for the AAP putting out a policy statement, like you use that in support, and I think part of the PPAC, which is part of SOPM, will go to the payers and say, this is new and we should include it. There's work behind the scenes, I think, that happens with that. Not always successful.
Okay.
There is work that goes along with that. And that's the other thing too, in the paper, they didn't say how to bill and code and, what if it's positive, like the P. I think this is one of their downfalls, quite honestly, is they recommend these things, but yet they don't give you guidance on, okay, how can I do this? How can I import it to a workflow? And then how can I get paid for it?
Look, the AP functions in the worst environment
There
possible.
we go.
A combination of the Catholic Church with the U.S. Congress. And they all smoke cigars and eat fancy steak dinners and drink nice wine. And then they
That's
come.
the board of pediatrics, Herb.
And they're worse. No, the board of pediatrics, they fly private helicopters and eat in Dubai with the money they have. But the problem is they never call an outside expert in implementation when they come with these clinical reports and figure out just what you said. How do you mechanistically operationalize this policy that we're proposing?
Suggest the workflow. Do you
Yes.
suggest they do it ahead of time? Do you suggest, I think technology hasn't kept up. That's one of our downfalls is you
So,
don't
but I have a
have
question.
ways to use these screening tools that are easy, like to be able to text it to the parent or download it in their portal.
Well, you
and
can.
have it
So I
auto-
was going to ask you, with the
Here's the
anxiety,
technology, these things.
with the craft, if you're in SOPLIN, you know about JOT forms. So you could use a JOT form and it's HIPAA compliant. You could
You
text
can
it.
do Chattis, but that costs you like $1,100 a year. There's a cost to it,
But-
and it's not
for the
automatic
craft,
all the way.
or the craft or the GAD.
Yeah,
Can you push that to the parents before they
Yes.
come into the
We've
exam?
done that.
Is that
We've actually
valid?
done that.
Okay.
Where it gets text to them, they can fill it out and it comes back and it's scored. And then not all systems will just upload it into the EHR. So there's some manual label there where it has to be entered into the EHR. Some people don't want to do the screening ahead of time, especially suicide, because what if they answer yes? Nobody's really
Okay,
looking at it.
so
at the
let
time of
me
the
just
visit.
focus on the anxiety
right?
for a second. And so that could be pushed and they can fill it at home. And then you have the information and populate it in your EHR one way or the other. And then you know what you're dealing with. And that's okay. That's okay. The depression screen, I think most people just do the PHQ-9. And that,
And I just want to make a point here. The PHQ-9 is not a test for suicide in kids. It is in adults. It's not validated in kids for suicide. So I just want to bring that up because some
Okay.
people that
So I'm
last
going to back up.
question-
Let's just think about PHQ-9, not the PHQ-9 plus 2, just PHQ-9. That has to be filled out by the child because often children, especially adolescents, don't share their feelings with their parents.
Correct.
Okay. So you cannot push that ahead of the visit. You got to give it to the kid to fill out.
They come in.
Okay.
Yes.
And all right. So that's a very important technicality of workflow. Then we get to, and I specifically wanted to address that, and so there is a PHQ-9 plus 2, which asks about, have you thought about, I don't know, the question is, have you thought about harming yourself or have you attempted suicide in the last so many days? And that has never been validated in pediatrics. So
Correct.
you using that, you are sure. Anecdotally, you may pick up somebody that will fess up, but you're missing, and we don't know how many missing kids you're missing. Okay. And depression is part of what the U.S. Task Force on Preventive Medicine says should be an annual screen of everybody over 12. So because of that, every payer, including Medicaid in every state, should be paying you to do that. And if they don't, they're breaking the law. But how do you hold them accountable? I don't know. But that one, the law says they have to pay you for doing it, but they don't. Like in New York, if you send a regular code for mental illness screening, like the MCHAT, sometimes they just don't pay for it. And then we talk about suicidality, and we're going to talk about one more time. You cannot do the PHQ-9 plus 2 in children or adolescents. It has never been validated. And you're not doing the right work. And so what most people, I think, more than I do, but I think the ASQS, the suicide from NIH, it's 5 questions, right?
Takes 20 seconds.
20 seconds. That one's tricky. That's not on Bright Futures. That's not recommended by the task force. Therefore, and the payers don't have any legal reason to pay for it. They could if they want to do the right thing. They don't have to.
If you're billing the 96127 for that, they wouldn't necessarily know what tool you're using, quite honestly. Like they would have to do an audit. So I think like I don't, and I think that if you're doing a suicide screen and now it's in the policy statement, you still have a foot to stand on to go in and say, and the Academy like referred to ASQ or the Columbia, the CSSR, which takes a little bit longer, are the 2 suicide screenings that are really validated for use in youth. So you don't really have a choice. Like you have to do one or the other. There really isn't a third.
So, but here's where the work hasn't been done. And this falls on the AP because they're the advocacy organization for healthcare and children in America. They need to get a CPT code and there is for depression. There's G codes. George uses them for depression. When you screen for depression, there's a G code. One says screen for depression and George, hello.
Yeah, I'm here.
What's the screen that you use for? It's a G code that says depression, screen negative. And then there's a G code that you use that says depression's positive.
Depression G code. I don't remember exactly offhand. G code for depression screening. And that's what they actually want to use for, what is it called? When they do the quality incentive programs?
Yes. All right. So we'll put it on the show
That's
notes.
for a quality program.
No. In New York, you get paid if you use that G code.
So it's I think it's G431.
Isn't that only if you're PCMH?
Yeah. I don't know how to do with PCMH, but
Yeah, I think it's PCMH.
But you do get paid for that code.
first, yeah. They don't pay for other codes, but they'll pay for that.
And so if we're going to implement suicidality screening in population-wide, universal populations, healthy populations, we need a CPT code that validates that work. And we need to get it through the U.S. Task Force of Preventive Services and through Bright Futures so that the payers are obligated to pay for it. And then you take a pain point of implementation away from the busy pediatric clinic. That work needs to be done. You can't just throw out there, go do this, and not give us the tools and the support to get it done. Now, it's very tricky, and I want you, Gene, to go over it very specifically. This is a test that needs to be done in the office. Cannot be done at home to be valid.
Not to be valid, to be safe. What if the kid answers yes and the screening is en route or like in your inbox
But-
and you're not going to look at it till the child has the checkup? You wouldn't want to have a positive answer sitting out there and not being addressed. So it's
Okay.
much
They're
better
gonna
to
fill
give
it
it
up for their checkup. They're
in
gonna fill it
full.
up for their checkup, not a month.
And so second, the other reason you don't send it is because the parents might fill it out, and they might have, the child might have never shared with the parents their feelings. And therefore,
Yeah, and we also had, when I was in practice, the 13 and up, the parents didn't come in the room in the beginning while the MA was rooming, because that's when those screening tests were done. So the parents weren't hovering, like, what are you filling out? I
Right.
had that happen, walk in a room, and they're fighting over this screening tool.
That's
not
right.
like, you don't feel that way. And
right,
like
right.
the kid is getting ridiculed for answering his screening tool. So we always, once the child had to fill them out themselves, the parent would be waiting. So we did the eyes, the ears, they would fill out the screening tool. And then if the mom wanted to come back for a little while, usually I would tell them they had to leave at 13 for the physical. Some people let the parents stay in, but there should be a place where that child can be alone and be able to share without having another observer there.
Yeah.
Yeah.
And here's something that I've watched, and this is a place if you're going to implement this and you don't want to have especially in the Spanish culture, the Spanish people like me do not like to be kicked out of the room when their child's in the exam room. That's just culturally insensitive. But a lot of offices do hearing screens every year, and they have to go to a quiet room to do the hearing screen, and the MA is already there. That's a perfect place to do the suicidality check because it's not intrusive, it's a separate area, and it gives you the information you need. Correct me if I'm wrong, but you can't just hand that piece of paper to a child. You're supposed to ask the questions as they're written off the child and check yes or no. Is my understanding correct?
That's the recommendation. Some of the studies have shown that kids are more honest if they're actually answering it on the piece of paper. So
Okay.
I would bet people are doing it both ways. What I used to do was I would give them the paper and then I would re-ask the questions quickly. Okay, so I see you, blah, blah, blah. I see you, blah, blah, blah. It takes like another 1 second to do that. And some of that was for efficiency too, because if they were doing it in the hearing room, I wasn't there. And
Okay.
sometimes I felt those questions were better provider to patient versus an MA who might not know them. That's an awkward person giving them the tool. So again, I think you have to customize your workflow on these
Okay.
things to your practice, like how your patients are. And when I saw 12-year-olds, I would tell the mom right there, oh, be happy you're here this year because next year we do some of this alone. So I'm giving them the heads up that next year they're not going to have this privilege of being there for the whole entire time. So I think, again, it's how you set up your workflows and what
You can forget it. If they're Spanish,
I got them out.
that mom's going to take that purse and land it on your head. And okay, and then if people want to see how this should be done, modeled, Feinberg School of Medicine has a video with Susan Sirota going over how do you do this with a teenager. And it's a wonderful video, and we've put it on the show notes before, and we mentioned it before. But Feinberg School of Medicine did a very good job on modeling how you do this. All right. So basically, this clinical report is trying to move us in the direction of getting this to be recommended by the governmental agencies that decide whether these are mandated and paid for. But we're not there yet. But you think that starting before the recommendations are completed will do a really good service for the kids.
Yes, I think you pick up one child one child who you may have saved from some traumatic episode. I want to just point out one other thing in that paper that I think feels important. The preventative visit is 1 day out of 365. Okay, so we shouldn't be so excited that the child was negative for suicide or depression on that day. And the recommendation is to at least identify at those interval visits if the kid is looking withdrawn, if they're looking down, especially if they're not your own patient, if you're seeing your partner's patient, look for some of these somatic physical signs that child may be having something going on. And I think now that we've gotten away from review of systems, I still think the important review of systems is taking 1 minute, one little minute. So how are you doing? How's school? You don't have to do a screening test. How's school going? How's your life? Kids will share with us. We all know that. But you have to prompt them with the question and give them the opportunity of time. So even in an urgent care setting, like this past weekend, I was in this section on urgent care talking to them about how to screen for some of these things in urgent care. And I think knowing that half of kids in the 30 days before they kill themselves have seen somebody, you have an opportunity to make a difference. So I just like on my pedestal, I'm like, please just ask. You don't have to do a screening tool. You can just ask, how are you doing? How's school? How are your friends? And they will share with you right away. So that's my takeaway message.
I think
Despite
you're
all
absolutely right.
screening.
I think you're absolutely right. But I think you're absolutely right. I think I say this often, from a public health policy point of view, the weight of the evidence is to be very tight. And we have to make sure that it does make a difference, it is cost effective, and it doesn't cause undue harm. Because we're doing things up on healthy populations. I'm going to be very sarcastic. If you're dying from cancer, they tell you that the side effects of the medicine that may save you is that you may die. The choice is easy. I'm going to die either way. If the medicine works, I live, I win. If the medicine kills me, I died a little sooner than I was going to die, but I'm still going to die because the cancer is killing me. So the weight of the evidence there is much less than on a healthy child. And then the perspective of the relationship between the pediatrician and the parents, the equation changes again. Because if I can save one of my kids from going into DKA, I don't really care how much it costs to screen him.
Yeah.
If I can save one of my kids from dying by suicide, which is totally preventable, I don't care how many false positives I have.
Yeah.
And this is controversial, but I'm not giving MMRV to any 12 months old. Even febrile seizures they don't cause a long-term harm, blah, 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 blah. Yeah. But you know what? MMR in one thigh and varicella in the other one is just as effective. And I don't want to see a febrile seizure in one of my patients. That's not public policy. That's just, I care about my kids. And I want to do the best work I can for them, the safest way I can for them. And if I'm doing a little bit too much, that's okay.
Yeah.
And people forget that those are different perspectives that we have and different hats that we wear.
For that, they're getting vaccinated. So that's the key, right? Does it matter they get one in each leg or they get it together? You did the job. So
Yeah. No, I don't want to give
again,
them
it's a
3 times the
personal
risk of it.
preference.
Yeah,
It's
3 times the
fine.
risk of a febrile seizure. Why? Then they'll have a febrile seizure because that'll be my luck. And then they don't want to get any more vaccines. Why put myself in that situation? Like I really am.
That's
I'm
your
going to
choice.
I really, with a straight face, I'm going to tell a parent, oh, febrile seizure is nothing. It's like getting a cold. Who cares? No, they're unnerving. Nobody likes to see a kid seizing, right?
No.
So, but the perspective from the examiner when you're with your patient to when you're a patient and you have 2 really bad choices to what we do or recommend people do when totally healthy are very different and the standards are different.
That's right.
I think this is important work that the Academy is doing. And Gene, you've always been a champion in this area. And I really thank you for that work because It is incredibly important work, and I think there's still a lot of learning to be done by pediatricians of what tool, when to use it, how to interpret it, and how to start a therapeutic intervention.
Thank you. Thank you, Gene.
Thank you so much. Thanks for the opportunity.
It's always great to see you, Gene.
Good to see you guys too.
Thank you.
Bye-bye, everyone.
Bye.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.